I'm going to talk about cranial osteopathy. If you call it craniosacral therapy, I really don't care what you call it. I don't stand on ceremony. I'm a pretty informal guy, actually, aside from the suit. You can ask me anything. You can stop me in the middle. You can heckle me. It won't faze me. It won't be the first time. I'm very sarcastic. I'll try and dampen my sarcasm as much as humanly possible, but not entirely. Cranial manipulation is something that's been around for a long time. It's, the osteopathic profession is maybe 130 years old, something like that. I don't teach dogma, and I'm not going to teach that to you. I'm going to start out with showing you a lot of the different popular philosophies that are thought about cranial manipulation. My experience as an osteopath, people will ask me around the world, do you know an osteopath here? Do you know an osteopath there? And it's almost embarrassing to tell them that most of the people I went to school with don't do any manipulation at all. So outside of the US, I don't know how familiar you are or are not with osteopathy, but outside of the US, it's all manipulation. So if you're in Britain and you see an osteopath, they are going to do manipulation to you because they're not doing medicine and surgery. And yet in the country where it's founded, people don't do it. Things have sort of leaked out of osteopathy and become other things and other titles that people have ascribed to themselves, and other modalities, name stuff after themselves. I don't have any Steve Sannett therapies. I have some bizarre Steve Sannett viewpoints which I'll share with you, and I'll try and show you everything as primarily as I learned it. So there's nothing that I've invented. I feel that it was beneficial for me to go through medical school and learn osteopathy the way that I did, because I have maybe a different or a deeper viewpoint on health and healing. Everything that I'm going to do with you is clinical. I'm not somebody who, contrary to how Paul introduced me, I don't know what you think of that. I do a lot of teaching around the world, but I'm not really a seminar institute, although I do a lot of seminars. So I had a very busy practice in Philadelphia for 20 years. I've treated the sickest, most bizarre, alternate universe, tragic, karmic cases. And I've gotten a lot of results where other people didn't get results, and I failed on plenty of things. When we were in school and we heard someone stand and tell us about all the constant cures they were getting, for me it was the emperor had no clothes. New clothes, not no clothes. Well, same thing. I said, yeah, that's not true. You're not real. You never fail in a case, you're not real. Everything I'm going to tell you is real. Any questions you want to ask me, I'm happy to answer. My day, back when I had a normal practice, was back pain, neck pain, headache, what you would think of for body work, which is essentially what I do. I did a little bit of medicine, a little bit of prescribing, did work with other doctors, didn't take people away from other doctors. I'm not anti-medicine. I don't think all medicine is bad. I don't have any of these viewpoints. I'm just one guy playing in a very big game. And there was another thought that completely went out of my head, so that's gone. Maybe we'll change it back. After 50, it's just, it's just right down reaching for words and whatever. So I've given you all the preamble. I do a lot of teaching, but I have gotten the strangest cases. Back pain, neck pain, headache are the biggest complaints that people see anybody for body work, no matter what you're calling yourself. It's the #1 complaint, back pain. And the other half of my practice has been just neurologically tragic things, autistic kids, things you don't know what to do with. And there's no protocols for that. I've had these weird genetics. I was in Egypt a few weeks ago and speaking to this one university, and they asked me to tie in how osteopathy works for genetic mutations. I'm like, really? I got nothing for you. I've had some kids with some weird genetic problems that have gotten better symptomatically, but I am not the guy to stand up here and tell you I'm curing cancer and curing strange things by human touch. What I will say is some people do get cured by human touch. I just can't prove it to you. So I'm just going to cut through the chase right now if you want to know what's standing behind me. Nothing. It's just my experiences with people. And between you and the patient, there's your energy, there's the patient's energy, and then there's the two of you together. Miracles can happen, and I've seen a lot of it. People in my profession don't want us to talk about it too much because they would rather be more mainstream. Or you get people who are just straight out gurus and they don't want to be based in anything that has any kind of science or reality. I'm somewhere in the middle. And I'll get into more why I'm in the middle later on this weekend. I believe your attitude and your approach to things changes what happens between you and the patient. Absolutely. You'll never convince me otherwise. I'm going to try and show you some science of why cranial osteopathy works. But absolutely, it depends on the practitioner. That doesn't mean that you're going to heal everybody, but it depends on you. So for me, osteopathy has been my own personal road, I guess, of self-healing by trying to help other people. Okay, so without further ado, this is me. History of, see, I don't need a pointer, Paul, I got this. I've not used the TV before, the rest of the world is still using screens. So, history of craniosacral technique. In my profession, if you go to one of our Cranial Academy meetings and you say the word craniosacral, you're going to be castigated for that word because they're really got a bug up their orifice about craniosacral work and what it means, and they hate John Upledger and so forth. And I've done everything with the Cranial Academy. I served on some of their committees, and I spent the better part of a year with John personally, and I got to know him very well. And he was one of the greatest men I ever met. So for me, the words, I don't care. I don't care what you call it. People still don't know what I do. My mother still can't explain to someone what her son does. That was a whole tragedy when I decided to do manipulation instead of regular medicine. So, but craniosacral technique or cranial osteopathy, whatever you call it, there's a number of people in recent history, and I say recent because this goes back thousands of years, not osteopathically, or William Garner Sutherland. That's probably the name that people know the most. But there's also a woman who's working independently, not connected with him, Charlotte Weaver, who had another theory of cranial manipulation. You'll hear a little bit of it. What I'm going to do this morning before lunch is just get you through the theory, and I don't know if we may get to the tables before lunch. The way this weekend will work is it'll be a little bit of talk, a little bit of tables, a little bit of talk, we'll go back and forth. But I have to give you the setup for why I think this is worthwhile to do. Robert Fulford had another type of model, another reason why he believed we saw this phenomenon. John Upledger believed it was a pressure stat model. Dr. Arbuckle is another name. I don't think these are names that you know necessarily. Dr. Arbuckle did a lot of work in the 1960s with kids that had cerebral palsy, back when these kids were being treated as complete throwaways. I spent some time, I interviewed someone who worked with Arbuckle, and she was quite an amazing woman. Viola Fryman, you may know that name because she does a lot of teaching around the world. She's started a center for children on the West Coast. So there's a lot of people that have contributed to it today. But all of them base their findings on 5 phenomena. That no matter whether you take craniosacral therapy or who you learn it from, there's 5 phenomena that we will base this on. I describe phenomena this way. If I'm talking too fast or you're not hearing me, just stop me. Also, if you have to say something to me, I'm deaf. Usually I'm speaking to people that English is not their first language, so this is a nice break being in New York, but I really can't hear. So that's like the truth, I don't hear too well. So if you see me on the street and you say something to me, I'll go, that means I totally didn't hear you. And then I've gotten outed, like later on, I'll be sitting at lunch and people ask me all these intense questions, I'm like, and then they want an answer to it, that's when I'm caught. Same thing if I see you on the street and you wave to me, I'll go like that. And you're like, hey, why didn't you? I'm like, I didn't know who you were. I was 20 feet away. So I got some hearing problems. So there's 5 phenomena. The phenomena is the sun comes up, and then we all think about why the sun comes up. You know, the Romans and Greeks said these gods are pulling it up, and later on we say, well, the sun's not coming up, we're actually revolving around the earth, and our explanations change, but the observations remain the same. And that's important for me in cranial osteopathy. Things that and I'm going to give it to you from Dr. Sutherland, things that he observed was that there was an inherent motility of the brain and spinal cord. We're going to use the words motility and mobility. Mobility is gross motion. We push a joint, we move something, we can see that it moves, we could radiographically identify that. Motility is going to be, it's absolutely going to be a belief system. Okay, we're going to tell you that there's an inherent small, tiny, not measurable motion that happens. Let's just leave it at that. Motility is the tissues moving by themselves, not in relation to something that we can visualize on an x-ray or something big. There's a fluctuation in cerebral spinal fluid. It's not a static situation. Cerebral spinal fluid is made in your ependymal cells. It gets reabsorbed in your arachnoid granulations. Everything that's going to come out of my mouth is in your notes. It's in the notes section if you're panicky about that. And this is all overview. So with CSF, it changes. It's not just the same. There's a mobility of the intracranial and intraspinal membranes, meaning that they are not, it's not a block, it's not a brick. We can forcibly move it. If you are someone who leaves this weekend and was not able to feel cranial rhythm, you can do cranial treatment by mobility. I teach everybody around the world. If you can get things to move, and if you believe the body has the ability to heal itself, which I do believe, then a little bit of motion, the body can do its inherent motility that it's doing anyway. Okay. There's an articular mobility of the cranial bones. They're not fused. They come together, but they're not closed. This becomes a big bone of contention with people that, in my profession, within the profession, that don't want us to talk about cranial manipulation because they're afraid it makes us seem not medical. Or with people who are MDs. I've had more than enough MDs say that what I do is, I have to be careful now, I'm being filmed. So it's a bunch of whatever, bunch of crap, right? And then they have a problem and it doesn't get fixed, they call and schedule an appointment, come in the back door. I've had more people, back when I had my practice, treated a lot of MDs who said very unkind things about osteopathy, and me in particular. Me, you can't hurt me. If you pay me, it's okay. Call me whatever you want. And the same people that would say stuff to me said nothing. If you could help their headache, they suddenly started referring a lot of patients to me. And we're all in that kind of business. So I had people that said, well, bones don't move. I'm going to show you this morning. You absolutely cannot leave for lunch. I'm not asking you to believe anything I'm saying. I'm going to show you evidence of why the bones move. And more importantly, we don't have time in this course to do it, but if the bones don't move, and if they actually do come together, it's called synostosis. Those kids look like monsters. They don't look like you. My last 4 years of practice, which my son is now running in Philadelphia, we're treating the Amish. And we had a lot of actual cranial synostosis because they're sort of inbreeding. They're not marrying first cousins, but the gene pool is not that large. So we would see a lot of these things. And when the sutures actually do close, they look horrific. They look horrific. In the old medical days, and even when I started medicine, which is a little more than 20 years ago, the term, we would see it in notes. I saw a 5-year-old FLK. You know what FLK is? No one knows?
I know it is, but
I know you know because I told you before. Mike's the one guy. He's the one shill in the audience, one guy I know. It's a funny looking kid. You know why it's not in the notes today, right? I explain to people overseas when they have all these illusions about America, and I say, well, you don't know America. America, a child's born, and then they're assigned to a lawyer, and that attorney will follow them throughout life and see who has wronged them. Okay, so you can't write in the notes, I saw an FLK. But it wasn't written as an insult to somebody. It meant like, the kid's just funny looking. They're just weird looking. It was just a medical observation. Now, if that kid had ADD or ADHD, no one connected the dots that that kid's head was tight. So I still saw that when I first started medicine, but of course you won't see that anymore. Okay, don't worry, we will get through all the material. Everything will be covered this weekend.
Oh, I have one question. Why do the sutures close? Because of the gene pool? Or why do they
I don't know. Say again, I'm going to tell you, I don't have research on it, but something doesn't go right if you're with your first cousin. Or if you marry your brother or your sister, something's going to go wrong in your gene pool. So what I see most are not actual synostosis or plagiocephalies, where the sutures are open, but they're restricted. In short, if your skull grows like a barrel, and it was like slats on a wine barrel like this, and it grows evenly, the brain starts to push the skull out, and you're going to look however mom and dad look, okay? If this is a suture here, and this doesn't allow motion, what we see is as the head starts to grow, it starts to grow into the suture. And there are some genetic abnormalities. I have a lot of photos that I do in another cranial course of aberrant syndrome will cause your skull, your sutures to close early. There's some other genetic syndromes that it's associated with. I don't know if they could say why it is, but the chances of you having like a frame shift mutation or some other type of strange thing happening to your genetics, if the gene pool is small, it goes up the smaller the pool is. I did some work in Saudi Arabia as well, and I saw a lot of horrific looking children, like weird shaped heads. And my colleague there, my counterpart there said, they're not marrying first cousins either, but they're staying within tribes. So still they don't have the variety. But when it does close, it absolutely makes it looks like something. Everything that I do is I treat, when I get asked what I do in the simplest terms, I treat tension. I give people the dumbest explanation that they will accept for what I do. I'm not interested in converting them to osteopathy. I'm not interested in them understanding it. We're not doing this together. The together part is they pay me, I treat them, I hope I fixed what they asked me to do, and then I'd like them to leave. Because I saw someone every 20 minutes. So, went off the track again, didn't I? I did. So, go back on track.
Actually, I have a question.
Yeah.
When they do brain surgery, do they use the suture lines, or do they just make a clean line somewhere else?
Not currently being a brain surgeon myself, I couldn't tell you. I can almost start to walk on that road like so many of my teachers did, where they start to give an answer for something they really don't know. So I'm just going to start there. If you need a brain surgery, they're going to do, again, I'm not anti-surgery. If you have something that needs to be removed from your skull, I can only guess that there's certain pathways that they decide before they get out the buzzsaw. And their concern has nothing to do with cranial mobility afterwards. It has to do with removing a tumor or an AV malformation or something god-awful. So that was an easy one for me. No idea. No idea. We're going to call this, Dr. Sutherland called this phenomena, that was responsible, he called what was responsible for those 5 phenomena the primary respiratory mechanism. You will see it as the CRI. People that are craniosacral people use that term. They're not actually interchangeable terms, but the proper term that Sutherland wanted us to use was primary respiratory mechanism. He believed it was the first thing that emerged in life and the last thing to depart in death. What I can tell you is that I probably coded, I want to say, more than 500, less than 700 people in my life. I did a lot of hospital work when I was a young doc. It's a low job, by the way. The real docs are home sleeping. But your big hospitals, they have some new doc to do emergency things, not in the emergency room. Someone who's in the whole hospital having a heart attack. So I coded a lot of people, and unlike TV, most people just go on to die. They're in the hospital because they're really sick, they got all these problems. And after we called it, and after we were done with the shock paddles and pounding on their chest, you still felt a cranial rhythm for maybe 15 to 20 minutes. I didn't get on their skull and do this so that I'd have everyone else asking me what I'm doing on the dead person. Okay? I was the person running the code and doing it, so I had the luxury of just putting my hands on them, and you can still feel something. The other thing, the opposite is true. I've had, in the Amish world, everyone is either currently pregnant, about to be pregnant, or just got done being pregnant. The average household is 8 to 10, and we did have patients that were 15, 16 kids. One was 18. That's one man, one woman, one uterus. Okay, so you can feel multiple rhythms. I've been asked to predict how healthy is a baby. I don't step into that puddle. If you've been spotting and things don't feel right to you, you go back to your OBGYN and do that. But I've never been wrong on that in my own head. You feel there's 2 people going on there. So as a rhythm, we're going to describe it with qualities of rate and amplitude like we would pulse or respiration. There's a certain bigness or smallness of the feel, and there's a certain rate how fast it goes. Depending on who you read, the actuality is you're going to find cranial rhythm is going to be something like 8 to 10, 8 to 12, thereabouts. It's going to be slower than respiration. Okay? If you're feeling a cranial rhythm that's 60 or 70, no, that's a pulse. It's going to be a very slow rhythm. There's a phenomenon that we call still point, which is the cranial rhythm will just stop. There's things that we're going to do to make it stop, and there's observations where you'll have that it just stops on its own. Unlike your heart, if your heart stops on its own, that's bad. If your cranial rhythm stops, we theorize that this is the body resetting its mechanism. What you will feel with each other is maybe you'll feel something pleasant, maybe you'll go to sleep, maybe you'll feel nothing. There's cranial that people do in a class. In the class, cranial is a great thing to do. It's fun. It's not like visceral. Visceral is like torture, half fun. Cranial, everybody's feeling the rhythm, everybody's happy, everybody's in love. I'm telling you, I do this clinically. So when we do this in class and we do cranial rhythm, everybody's gonna have a good time. It's just fun, you know, touching each other lightly and, oh, did you feel that? Oh, I felt my body shift. You know, it has a certain value, which is really tiny, okay, because you're not really ill. When somebody brings a kid to you that can't breathe right, or is autistic, that is a lump of flesh that walks around following the parents and doesn't integrate with the world at all, okay, you need to do something real. You need to cut through all the stuff. So I'm going to teach probably in a different way than some of the ways you've been exposed to. I'm going to try and keep it as real as possible. I want you to have fun. I want you to be in love. We should all be in love. If we were in California, everybody's in love. You just walk across the border. I can't say something else because it's on camera. My friends in California, but yeah, there's reasons why they're all in love, I think. Okay, body rhythms. I think of body rhythms in this way, and I'm going to go back and forth in my introduction talking about mobility and motility. Motility is that inherent rhythm. We're going to try and feel that this weekend. If you don't feel it, you're going to go back with your clients and start integrating just some of these motions we're doing. I think if you try and integrate some of these mobilities and spend 2 minutes of your time trying to palpate something, 2 minutes of your time on every patient, I think it won't be more than a few weeks, maybe a month or two, you will feel this rhythm. That's what I think. I'm not asking you to go back to your practice and radically change tomorrow what you do. If you're spending 20 minutes, half an hour, 45 minutes with your patient, I'm asking you to take 2 minutes in some different parts and just stop what you're doing without discussing with the patient what you're doing. No pressure on you. And see if you can become aware of some other rhythm. I think you'll become aware of it. What I've tried to do here is just to throw together some other rhythms that we don't challenge at all. If I make this black one a cardiac rhythm, we'd say it's very fast. You can palpate this throughout the whole body. The heart squeezes, and the motion that's set in, the motion that is caused by the heart is palpable everywhere through the body. I did respiration to show that it's a much slower rhythm, this blue line. Cranial, I gave, what do I give that, a red line. I said there's another rhythm, and visceral is even slower. All of these things are happening everywhere in the body all the time. So how are you going to palpate it? It's a matter of turning your attention. When I was in medical school, I'd sit in the basement, I had the book on my lap, I used to listen to a shortwave radio. I used to listen to some overseas broadcast, and I'd have Clint Eastwood or Steven Seagal, 2 vitamins for me, on the TV killing people. And I'd have all this noise on, and while I'm studying, my wife would come down and she'd go, how can you possibly study? Well, I'm paying attention to this, but I like all the noise. It's the same way with cranial. You don't need to have a quiet situation. I had some patients bring a child to me in the Amish world, and they said, do you do cranial in children? I'm like, you come to my office, and it's me, my son, and another osteopath who I trained many years ago. And it is so loud, there's so much kids and screaming and yelling and snotting going on in that office. They said, we went to another place and they said they can only treat the child if the child's well behaved. I'm like, really? What child's well behaved? So some of the kids that I'm treating, and it's like riding a roller coaster ride. You can do it. It's nice if you have this perfect situation. Lights are dim down low, have music on, everybody's concentrating. That's not my real world. My real world 2.5 weeks ago was in Egypt, and they brought me just the most crippled, screwed up, misdiagnosed neurologic kids that had cerebral palsy, some of them undiagnosed, and I had to have the parent hold them down at the table while I treated them. Hold them down. I have fish hooked kids in the mouth and been bitten so many times from doing intraoral on them, and the treatment sometimes works and sometimes doesn't. It has nothing to do with behavior and wellness. Yeah, okay. Respiration. Respiration tends to mimic what we feel in this craniosacral theory. When you take a big breath in, it's going to mimic our motions. We're going to look at all the individual motions this weekend in the vault of what actually happens during a cranial rhythmic impulse. We're going to see the bones move in a certain pattern. We're going to feel that pattern from head down to the toes. That pattern is mimicked by taking a breath in. When we learn things in school, we learned to have people hold their breath so we could feel something more, or to try and assist what we're doing in cranial. And that's okay. I'm just going to tell you again that I'm in the real world. So I don't do anything like that. I don't have people hold their breath. I can work in the middle of a storm. You can do it. Okay, we're going to look at the major, I want to give you all the major theories. One of the things that has been a personal pet peeve for me, among my many personal pet peeves, is different things in manipulation become almost like a cult. You belong to this church, you belong to that church. And you have to drink all the Kool-Aid or none of it. Okay, and you can't challenge anybody, you can't ask a question, because you'll just get people, you'll get them angry. Okay, if you ask them a question that they don't agree with or they're not prepared for. So there's 4 different big theories of cranial. One is a bony model. This is what Dr. Sutherland worked off of initially. That something was happening in the bones that was causing this phenomenon. Dr. Weaver believed this also in a different way. John Upledger believes that the brain is the vault is a closed hydraulic system, and that's what's causing this motion. CSF is being created and it's being reabsorbed, and that's why the skull is deforming. Dr. Fulford believed that there was a membranous model. It was all happening because of something innate in the dura. And lastly, this is probably the most popular today, the biodynamic model. That comes from not osteopaths at all. It comes from Dr. Blech, Schmidt, and Gasser. And Gasser, I think, is still alive. It's like 1002. They were anatomists who later on came to Dr. Sutherland, and Dr. Sutherland embraced some of these ideas as to why we see the sunrise. Okay, so it's a different thinking. I really like this biodynamic model. It explains for me a lot of energetic things. But all of these models are flawed. Okay, so people that want to belong to this group or that group and say, no, this is the right way of thinking, I've reached a higher state of consciousness, we can poke holes in all of these. And I don't think about any of these when I treat a patient. The way I treat is very different from what I was taught. The way I treat is it's an empty space when I'm treating people. I'm not thinking about, well, I'll tell you what I'm thinking about. I'll tell you later what I'm thinking about. This is what I think a lot of osteopathy has been for me. Okay, they have these equations, then a miracle occurs, and then you get to the end of it. At some point in all the theories, there's something that doesn't add up. 1 + 1 does not get you to 7.5. I just don't get stuck on the fact that a miracle occurs. I'm not here to convert you, to have you believe what I believe, but if you believe that all healing comes through Jesus, comes through Allah, comes through nature and energy, if you believe in none of those things and you're an atheist and you believe that the human body has the ability to repair itself, any one of those interpretations works for me. Because I've seen people get well that shouldn't be. There just isn't the explanation. And I've watched good people have mild problems and go into a miserable death that shouldn't be. I do not spend too much time thinking about that. Because if I do, then your objectivity is lost. And the difference in doing cranial osteopathy or doing CST is you are the tool. There's the element of theory of what we're going to talk about. Here's how you release the ball, here's how you push. Okay, it has a certain value. I can show a robot how to do a certain value of treatment. The other value absolutely is you. But if I'm treating and I have to get too involved in why this happened to them, then I become sympathetic. If you become sympathetic, you actually have less power, you have less energy. So you have to face them knowing you may fail, and you have to be okay with that. I don't mean be happy with it. I mean you have to be okay with it. That's the only way you're going to work as a pure vessel, if you believe that energy is working through you, and that's what I believe. If you want to know what I actually believe, that's what I believe, that there's energy. You can call whatever you want and give whatever names or spirits you want to it. And when I'm in different cultures, I will change my verbiage. I found that I don't want to offend people. It's not for finances. It's just I want them to have the opportunity to listen to what I'm saying. So if you're in one culture and they don't want to talk about anything with a religious interpretation, I don't. If other people see everything through another religious interpretation, I leave that possibility open. Because I'm not here to challenge you. I'm just here to show you why what I do works very often. And the reason why it works very often is the techniques are good, which you're going to learn, but it's also the technician. So you have to face this as a fallible person. Me, I embrace the horror. I embrace my failure. It's just easier. I no longer have to worry about it. I'm too damn old to face an exam every time I'm treating a patient about whether or not I'm going to help them. Okay. All right, so what we're going to do this weekend is going to be the vault. And of all the things I get asked, in my previous incarnation, I was a karate guy. That's what I used to do. Didn't always have this. Didn't always have the baby. I did martial arts for a living. And used to compete, train people that fought at the casinos, a lot of tough guys. And you know who the toughest people were I fought? There were people who did the basic stuff really, really well. It was nothing that I see Jet Li do, which I wish I could do before I die. None of this whipping around up in the air and finger of death technique, you know. None of this mysterious stuff. People knew how to do basic stuff faster and harder than anybody else. And it's the same with cranial manipulation. What we do on this weekend is the best stuff that I know. On an advanced course, we talk about a lot more weirder stuff, intraoral stuff, and stuff that I use much less frequently. But if you don't release the vault, nothing happens. If you don't do the basics really well, you're missing out on everything. And some of the people that I learned from that showed me some great things. There were people that were treating patients for 40 years, 50 years. They could never stand up here at the microphone and use the language I'm using because they don't either never had it or don't remember it. They've just been involved in human healing for 40 years. And they're very clear as a person. They do basic stuff really well. Okay, so we're going to release everything that contains the brain. That's what the vault is. We're going to essentially look at 5 bones: frontal bone, parietal, sphenoid, temporal, and occipital. We're going to do them, by the time we're done, you have a 1-page thing that is a protocol. Protocol is just things I wrote down for you not to forget. I don't do everything that's on the protocol, but I do 90% of it. If I'm doing a cranial treatment on you, I'm going to address all 5 of these bones at some point. I'm going to do the diaphragms, and I'm going to do something to your sacrum. You can do treatment, and we will talk about specific things, specific lesions of the temporal bone, specific lesions of the parietal bone. That's one way to do treatment. I think that's the lowest way, in my opinion, to say, someone has this problem, let's connect it to this part of the skull. Another way to do treatment is to say, I'm going to evaluate everything that contains the brain and see if I can create motion where motion isn't, so that whatever is there mysteriously can function better. I think that's a higher way to do it, in my own opinion. Best way, I think, to do it is to look at their entire body and look at where energy, fascial restriction, whatever you want to call it, doesn't flow. And that may have nothing to do with the complaint they came in the door. That's a very old, at least in the osteopathic world, it's an old osteopathic idea. And what things have become, at least through my osteopathic school, has become more like a quid pro quo, do this for that kind of thing. This treatment is good for that thing. Okay, so there's a lot of different ways to look at a person. We're going to look at the general, this is all overview still. And actually, Paul, I don't know if you want to keep time and tell me when people need a break, or I figure like about 50 minutes, we'll just take a little break and then I'll do some more. Yeah, about that. When I was in Korea many years ago, it was a big group, it's like 100 people, and I just kept talking. If I had to go like over an hour, I just keep talking. I want to finish what I was doing, and I just could see everybody's getting nervous. And then finally, my host, and they were just nervous to talk to me about, to give me like a correction. He goes, Dr. Sennett, the student need a break. And I go, well, I'll be done in like 10 minutes. I just want to. He goes, oh, then the student they need a break. And I realized what it was. Because at that time, everybody was smoking in Korea. At break, everybody went out into the hallway and had their heads in the wintertime. Everybody's hanging their head out the window and puffing out the window. They needed a nicotine break. It wasn't like a boring break. So before everyone, starting to keel over in about 10 minutes, I'll just take a break. We're going to look at all the structures inside, how things are moving against each other. This is a living, dynamic area. Yep, that's what I want you to know. Oops. We will look at the specificity of the sutures. There's a certain way the head is shaped that's within normal limits. We'll talk about all these sutures, coronal suture, sagittal suture, lambdoidal suture, how they come together. If we look on the inside, we see little arachnoid granulations and things that indicate that this factory is working here. Your body is this living physical and emotional and I would say energetic roadmap of all your experiences here. And it's all written all over your body. We'll talk about some of these important holes in your head when we look at specific nerves. We had to memorize all these things. It's perfectly useless to just memorize it and say someone has this, and I'm going to give you all the same information. Someone has this problem, and it's because they have a vagal. It must be a vagal nerve problem, so it's between this bone and that bone. That is a low way to practice cranial, and in my opinion, it's a low way to practice cranial. I think there is one part of your brain that should study all of the holes in the head. If you really want, if cranial is something that's important to you, I think you should know the anatomy. And if I use the left brain, right brain analogy, at one point you study it, and then you just forget it. Your processor knows how to access that information in the background. I think if you were, if you're some kind of angel, maybe you can just touch people, make them well. That's unfortunately not me. So I've studied, and then I do want to help them. The attitude is important, but I'm not thinking it while I'm touching. You're not doing those two things at the same time. You are not sensing and trying to figure out mathematics in your head at the same time. You're either doing one or the other. So we will look at the specific anatomy when we get into the individual bones. These are John's slides, John Upledger's slides. If we look here, we can see that these bones, every person is going to have more or less these kind of sutures with some little variations. This doesn't mean anything, this little square bone here. That's probably some injury that happened in utero or something, a little piece of the bone broke off. But this squamosal suture will still function the same. This is lambdoidal suture, and this is sagittal suture. Here's your sphenoid bone. If we look from above, this is the nose. Here's the back of the head. We call this interdigitated, like digits, fingers coming together. Okay, while these squiggles aren't the same on you or me, we all have those squiggles coming together. This is bregma here in the lambdoidal suture, also interdigitated. Again, these little bones, there's a name for them. You call them wormian bones, just something that broke off, and it's not changing any function of that skull. If we explode the skull, what we see as we go closer is we see more specificity. We don't see anything random. So Dr. Sutherland theorized that there was some motion happening here. This area is never actually closed on you, or it will close after a period of time after your skull is grown. But when it closes early, we do see problems. These are the screws you have in your head that in some of us become loose. Yeah, that joke doesn't even work here. It doesn't work. Translate. Some places it works. Sometimes they're just laughing, but it could just be inappropriate laughing. Like, I don't even know if they get the joke, but they're just laughing at me. That's okay. If we go closer, we just see more specificity. We see difference in the specificity between these two sutures. All I want you to see is that there's purpose. Something must be happening here for this to be. Bones grow for two reasons. Those two reasons are what? This is the audience participation portion of the program. I'll give it to you. You don't have to be embarrassed. I just want to, interact with you back and forth. You can have a head that's weird shaped, and the Amish, because they're very strange, they're very anti-traditional medicine. So they bring me stuff with, Jonas's head is I don't like the head shape, and I look at her head, and it's the same head. Well, this isn't something for me to change. That's what you got. But two things are going to make that shape. One is going to be a genetic map that says you're going to look like this, you're going to look like that. The other one is that bones grow along lines of stress. Okay, and this is some area where something dynamic is happening, something is changing. This is still at that intersagittal suture, and what I want you to see from this is that there's the interdigitations, the finger-like projections here, and then this, if you can see it, it's flat. John Upledger said to me, he theorized that maybe the interdigitations allowed some motion, but the flat part was like a buttress plate. It limited absolute motion. It's just theory, but it's reasonable. Because in other parts of our body we have motion. It doesn't have one set of brakes. For me to straighten my elbow out, or for me to extend my shoulder, or to turn my head, the soft tissues are going to stop me at some point. Right? If I go like this, what stops me? My stare can be very uncomfortable after a while. Don't worry about it, I'm just having fun with you. Okay, what's going to stop you is going to be muscles and the fascia. That's what stops me. And then the operator can take me further until the bones and ligaments stops the operator. So we have these multiple sets of brakes in our body, multiple sets of integrations. This is the temporal bone here. Here's the zygomatic arch, and this is the squamosal suture. This is also interdigitated, but instead of being like this, it's interdigitated this way. Dr. Sutherland theorized that the way the bones came together was the way the motions were limited, or the motions that could happen, that we're going to discuss. Again, if the whole theory is hogwash, it doesn't mean anything. We are going to palpate some motion, or we're going to get some mobility. So this is theory. Now let's look at the intersagittal suture. Well, if these bones are fused and come together, then this doesn't make any sense, because this is collagen. This is not bone. This is not bone. This is collagen. This is an active river. What's that? Arterioles, venules, big venule. How do I know which is which? The arteriole has a thick tunica muscularis, so they retain the round shape. The venules collapse, but it's a living area. There's nothing dead about it. It's not a pattern that was made and then left alone. It's a pattern where things are happening, things are changing. If we look closer in, we can see collagen fibers inserting into the bone. If we go even closer, again, here's some arterioles here. This is a venule. And you can see pieces of collagen inserting into the bone. The closer we go in the human body, the collagen is staining red. The closer we go in the human body, we see more and more order. It's almost like going subatomic. You know, at one point, when you learned in school, I learned in school the Bohr model of the atom. It was a dumb moment now. Retard. I can't say retard. It's an inappropriate, socially unacceptable word now. But that's how I grew up. Protons, neutrons, and electrons. That's what we learned, right? And then they learned subatomic particles, and now they learned string theory. These are all to explain our world, and the theories work until they don't work anymore, and they find a new way. And what they always find is they go smaller and smaller and smaller, and they find more and more order. I think it's interesting. This is a little nerve fiber coming into the intersagittal suture. This is a little blood supply tagging onto it. The whole area is alive. What's the nerve fiber doing? No, you'll never sit here again, I know. So just relax. I did this in Egypt with, I don't know if they're even understanding me, there's like 150 people in the room. I took the microphone, I was doing something, I took the microphone, and then I just went up to somebody in the audience and just completely paralyzed that I was asking a question. What's a nerve fiber doing? I got no idea. You know, I have people that would tell me it's doing this and it's doing that, and it's all, I don't know what it's doing. But it's giving some information back to the brain of that person, of what's happening in that suture. It's a live situation. It's a dynamic, changing situation. If we go very close up, electron microscopy, we can see collagen, individual collagen fibers inserting into the bone. Pretty cool. Okay, that supports our bony model. Let's look at a pressure stat model. Pressure stat model says, this is John's model, John Upledger's model, is that we have ventricles, you have the choroid plexus and ependymal cells that are creating this CSF, and that at some point the skull is enlarging, and at another point it is starting to shrink, and that's what the impetus is for the motion that we feel. He says it's a closed hydraulic system. It's produced and it gets resorbed in these arachnoid granulations. If we measure the distribution of cerebrospinal fluid, we can measure it all throughout that area contained in the dural sac and find cerebrospinal fluid. We can also find it outside the brain, in the arterial blood and in the venous blood to some extent. This is a slide I just added in the last few months. It's a mouse. It's the artery of a brain of a mouse, and this green is showing a fluid channel outside where lymphatic fluid is leaking out of the brain. It gives credence to the thought that cerebrospinal fluid is not just in the skull, that's leaking out into the periphery. Well, that shoots a hole in John's model that it's a closed hydraulic system. It can't be closed because we know it leaks out. For me, it doesn't invalidate the whole model. All of the models are flawed. And if we go into our professional meetings, they have the models they're married to, and then they love to shoot holes in this one or that one and say that, see, these people believe the wrong thing, like they're on the ship that's going south. For me, John was a great man. I think he raised consciousness for the idea of touching someone can help them. And especially where I spend a lot of my time, which is the third world, where they don't have the money for what we have. They don't have the drugs, they don't have the access to surgery. Raising consciousness for touch therapy is a good thing. Let me do one more slide and then we'll take a break. So what does CSF do? Well, if you didn't have CSF, your brain would herniate. That would be bad. You would have uncal herniation, your brain stem would hit the foramen magnum, your respiratory centers would shut down. So you need your brain to be floating. It protects you from shock, and it gives you some chemical stability. It's a harder area to reach, and for medicine, it's a harder area for us to treat because there are a lot of things that won't cross that blood-brain barrier. By the way, you also have two other areas of your body that have a blood-brain barrier with fenestrated fascia that helps protect it. Do you know what they are?
No, I don't.
I know, I got the head nod this way right away. It shut me down before I even got there. If I tell you that a woman has one and a man has the other one, did that help you out? Not at all, huh? There's a blood testicular barrier and there is a blood placental barrier. They're just considerations for pharmacology. The body is just this wonderful machine that is set up to survive here. You're set up to have all these traumas. I've been in these, among my colleagues and other people talking about these different cranial things and how this touch does that, and you need 5 grams of pressure in the skull or the head will explode, and here's my answer to that. I'm okay. Most of us are okay most of the time. Skip the spiritual question as to why some people do that and they're not okay. Okay, why some people have a small trauma. Physically, that trauma has to vector somewhere, we can explain it, but sometimes that small touch does make a difference. What makes more difference is, I believe, the operator. Let's just take like a 5-minute break to go to the bathroom, get a drink of water, hassle Paul.
There'll always be more.
There'll always be more, Paul. That's the definition of the word more. Different people from different disciplines. I think osteopathy or cranial, what we're doing this weekend, it's the best for you to integrate it with what it is that you know and what it is you understand. We had lots of lectures from people that literally stood at what I would call a pulpit, and you had to buy into the whole thing and give up your own dogma. I don't ask you that at all. So whatever thing that you know currently, I think it can be greater. I think it can be greater than what I know. Okay, this is just a parietal window. It's called a parietal window to cut that hole in and look at the membranes. And these are mixed in with some slides from John Ledger. We're going to talk a lot. The membranous model says that this phenomena, this observation we're happening, it's not because of the bones, it's not because of the fluid, it's because of the dura mater. And regardless of what models you subscribe to, the dura and the dural connections becomes very relevant. The dura mater is this thick connection below the parietal periosteum. Because it's very tough in the, who's done dissection in this room? Done a dissection, seen a cadaver? Okay.
I refused on the frog in biology.
No.
Pardon me?
I refused on the frog in biology.
I'm sure the frog is appreciative of that.
My frogs, thank you.
You know, I've eaten so many things that are just wild in my life. And my friend Alfred in Hong Kong said, do you eat frog's legs? I don't remember if I've ever had them or not, but I'm like, yeah, I could do it. I think I could do it. Okay, I didn't know they were going to be live when they brought them. So he brought this whole jiggly pan of a bunch of legs that are still going like this, and you had to cook them in the thing. And I've gotten embarrassed, I guess, into just eating a lot of things to try it once. But I don't want to do that again. I get tired, in China particularly, you stop asking them what it is you're eating. Because you'll probably be offended if you know, and then maybe ill after you find out. It enhances the experience. So the dura mater, in a cadaver is one thing, in a live person it's quite another. It's very thick, like sailcloth. You would be hard pressed to tear that with your hands. Below that is an arachnoid matter that's like a spider web. And you could just pull that away easily. And then there's a pia mater, which is, you can't distinguish it from the brain. It's only cells thick. So we will talk about this dura mater, this thick connection that connects all these bones together. This is another view of it. So here's your scalp, here's the bone. You'll have actually a periosteum here, and then this dura mater will connect these bones all the way down to your sacrum. And we'll look at those connections. This is a picture from if you want to get yourself a book on cranial, most all the stuff that is out there does derive a lot of stuff from Sutherland's original work, which was not a book that he wrote, but it was a book that he approved, that Magoon wrote, called Osteopathy in the Cranial Field. And the drawings are really poor. This is showing the dura overlaid over the cranial bones. I tried to show it side by side. So this is the petrous ridge here. Petrous ridge is the temporal bone. This is the lesser wing of the sphenoid. Clinoid processes, anterior and posterior clinoid processes. And everywhere where we see these ridges inside the skull, Paul, we don't have like a skull here or anything, do we? Or will we have tomorrow? Oh, we do. Bonus. Okay, great. All right, so all these, nice. All right, so all these ridges here are signs of bony attachment. And you can think of this dura, if this room was the vault where the brain is, the ceiling, the floor, the walls, and you thought of the dura as this material that had hooks in all the walls and could control the tension. That's how you can think of the dura. And then it goes south down onto the sacrum. Here's another view of it. Here's the nose. This is a dural duplication. There's 2 layers of dura. I'm going to go through the anatomy and prattle on pretty fast. If you don't remember, something's not familiar, it's all written down in the notes. Is it necessary to know it all to do the application? No. I just want you to hear it. Just hear it. But this dura comes together as 2 sheets, and then it splits, and we call it a tent, tentorium cerebelli. It tents over the hind brain. It's another view. This is the nose, this is the back. In this sheet, there are areas where the 2 sheets split and they open up and come together. You know what's in the open spaces?
Ventricles.
No. Good guess though. No one? That's where the venous sinuses are. Venous sinuses collect blood from the brain and it drains out. The difference between a sinus and a vena and a vein? Any thoughts on that? I promise I'm not going to ask you another question. The venous sinus, a sinus is a space, so it's areas where blood collects. The difference between that and a vein is a vein has a tunica intimata, tunica muscularis, and a adventitia. It has layers. It's a muscular tube. A vein is just an area where it collects, but this isn't contractile in that same sense. Little caveat, you can use at parties with your friends, or not. Okay. Another view of the tent splitting over here. Here's the posterior clinoid processes. Your pituitary gland sits in there. Just a close-up of the fibers. These fibers have a directionality to them. The directionality to me and to Beryl Arbuckle and others indicates that there were some forces being transmitted. Okay, there's some forces being transmitted through the skull. There's reasons why you bang your head, and for most of us, most of the time, it's not a problem. Even some severe head bangs, some big falls in the pavement, it's not always a problem. It has to do with the force in and the force out. The force can go out perfectly, you're left without a problem. That's how, the karate things we do, breaking boards and stuff like that. It's all kind of a game of targeting and directioning forces. I don't think the karate people actually know that. We learned all these mystical reasons why we break the boards, and none of that is true. None of that is true. It's just a question of force. Why the board breaks and your hand doesn't. Another close-up of the dura. All I want you to see here is the fibers. Something is going on. Something's being redistributed. The dura, you should memorize all of these. Not really, just a joke.
We knew that.
Pardon me?
We knew that one.
Yeah, don't memorize any of it. But I've written it out for you. Some people are very need to have to see it. So it attaches everywhere along the brain so that it can distribute these forces. We're going to talk about specific motions after this lecture is over. What that motion is, that craniosacral rhythmic impulse, that primary respiratory mechanism. What actually happens when we say that the cranial mechanism is moving? We're going to say that it goes through one motion that we're going to call flexion, and I'll show you other pictures. This is just overview. And we're going to say that this dura, we're going to say that the skull reforms, not that it gets bigger or smaller. Pressure stat model says it gets bigger and smaller. I have a little conflict with the bigger and smaller because your brain doesn't like pressure changes. The brain's a very sensitive area. If it was actually getting bigger and actually getting smaller, I think theoretically that would be less likely than just deformation. Deformation we can explain easier. It would keep the pressure constant. So we're going to explain a deformation in a more complicated way. I've listed some more attachments here where the dura is going. We're going to see that during what we call the flexion phase, that the anterior posterior diameter from nasion to epistion, more or less an AP axis through your head, is going to become slightly narrower. And the width is going to become slightly greater. Is that measured on some sort of MRI? No. It's just something anecdotal we all talk about, we all sort of believe in. What you will feel maybe when you begin is that the head seems to get bigger to you and seems to get smaller, depending on where your hands are at. Or you may feel nothing. The simplest, once you start doing this on patients, when you feel the real abnormal, particularly some of the tragic cases that I've seen, there's no question that it doesn't feel like a normal head. For me, it's been an interpretation as weight. I'll feel, maybe I can show a pediatric video, we get a break somewhere along the weekend. I have a little kid I treated with just a little tiny coconut for a head. And it just feels like I'm lifting up 50 pounds because there's almost no motion. The motion is really poor. So at some point, we talk about the theory, you lay down with someone who's quasi-normal, we'll call New Yorkers quasi-normal, okay? And you're going to say, I feel something, I don't feel something. You take it to your pathologic patient who fell 20 meters or fell 10 meters down the stairs and smashed their skull and has some severe problems. You will feel abnormal from the normal. It's much easier on where there's pathology than where you're just guessing about it. Just another picture showing the same thing here. These, if you can imagine, this is just the way I'm standing here. You have these two sheets of dura actually. So it runs this way, and then the dura opens up, it goes together and opens up, and that's what makes these areas we call sinuses. The cranial theory, actually it's this way here, the cranial theory says that middle, that if the motion is happening in that membrane, that there must be a center point of tension. This is more a brain thing than, you don't need this to do manipulation, but people talk about the Sutherland Fulcrum. They say that is in this straight sinus. Sinus, again, is where area collects from the brain, and then it will drain out through the jugular foramen. Some other areas of interest. Meckel's cave is this area where you have a fold of dura that actually comes out into the face. People will relate things to someone has Bell's palsy or trigeminal neuralgia. You need to treat this area, ... I've treated a lot of people with that condition, actually including my mother. One of the few times I was ever successful treating my mother. Family's the worst. They're the worst. Don't treat your family. Send them to your friends. Well, they might not be your friends afterwards, I don't know. Family, they're not going to pay you. They're not going to get well. They're not going to leave you alone. It's the gift that keeps on giving. So my mother got a trigeminal neuralgia, and she wouldn't listen to me anyway. And it's just funny, I treat my father easy. I treat my father, he feels good, easy for his problems. My mom, impossible. You know why? I love them. What does that mean, that you love them? It means I'm not clear at all. You can't treat people that you're really in love with and people that you really hate. It's much easier people that you're not connected with in that way. To treat a patient on a higher level, I believe, you need to be empathetic. I need to be where you're at in your skull at that time to try and release something or to try and nudge your body in the right direction. When I feel sorry for you at the same time or angry at you, I cannot do that clearly. But I treated my mother for a Bell's palsy. And the treatment was, I didn't arrange it around, oh, the Meckel's cave because she's got this problem. I just did cranial treatment. We'll spend a lot of time talking about, on our last day, of the different diagnoses for the sphenoid bone. Two areas that people get confused on in osteopathy, at least in a brain way, they get complicated, and that's talking about sphenoidal diagnoses and sacral axes. So we'll spend a lot of time talking about it. Charlotte Weaver, that gets hardly any credit for doing anything, was working around the time of Dr. Sutherland. She had a whole theory of the dorsum sellae, which is not in this picture here. It's a little appendage that should be off this off these anterior clinoid processes. A little appendage here that she believed was moving with some sort of rhythm and was germane to what happens in your pituitary gland in the infundibulum. So her model is more of an endocrine model. That's all I want to say about her, because she's not gotten credit where credit is due. If we look at these attachments, this is back of the head, here's the front here. This is the greater wing or sphenoid. That's what we're palpating on the outside. This is our cranial theory. Our cranial theory says that we said that there's an inherent motion, a motility, something that it does on its own that's very small. That very small we estimate to be on the order of 500 microns or less in motion, which means less than 1/2 of 1 millimeter. To my knowledge, no one has been able to measure this today. When I have seen things where people said they measured this and that, it's a study of n equals 5. This is not a study. Okay, this is not, I don't know if it's met any kind of real scientific standard. So we estimate this tiny motion to be small. And that motion, if we said that it had a rhythm, I said it would be something like, 8, 10, 12. It could be a little slower, it could be a little faster. If we gave it a rhythm of 10, rhythm means it has a down part and it has an up part. Then it will go into what we're going to call flexion for 3 seconds and extension for 3 seconds. That's a rate of 10, right? 1, 1,000, 2, 1,000, 3, 1,000, and the other way. 1, 1,000, 2, 1,000, 3, 1,000. Okay, that would be 1 times 10. That's right. My math is right. Okay, so 10 would be 3 seconds each way. So it's very slow, plus or minus. You're putting your hands on the head, and that motion, all of the theories, they differ in what's making it move, but we all agree that we feel that motion. And that motion is that something happens between the base of the sphenoid and the base of the occiput. That's the center of motion. And it rises up. We call this the flexion phase. That's going to cause the sphenoid bone to roll forward, the frontal bone to roll forward, forward being down to the feet. Feet are down here. The occiput is going to go back down towards the feet. The dura is being pulled up. This is overview. You're going to get it more specifically. If we go to this dura contracting, we see the AP diameter decrease, the width gets slightly wider, and this pulls up on a firm attachment in S2. Got a headache yet?
You're saying that this motion is less than a millimeter? That motion?
500 microns is half a millimeter, 1,000 microns is a millimeter.
And that's this motion?
It'll always be more, Paul. That's the definition of the word more. It's a little private joke, Paul, I know. We got to get more private jokes. I need another one. Okay, so this motion, what we're saying is there's some deformation that happens that results in the skull getting the AP diameter changing, the width changing, and the sacral base going backwards. I said to you it was mimicked by respiration. If I take a big breath in, my sacral base has to go backward. As for those of you who do yoga, tai chi, things like that, you take a real big breath and it fills up your pelvis. It does push the sacral base backwards. Okay, it does pull down on the occiput a little bit backwards. For all of the cranial theories, our direct physical link to say why this works and why it's palpable through the whole body is that the dura is attached throughout the skull, through the dentate ligaments, through all the neural foramina, all the way down to the coccyx. So we say that the single bones go through this motion of flexion and extension, which we will look at specifically. And the paired bones, we say, go through internal and external rotation. If I take a big breath, to some degree, your bones open up, they move. We call this external rotation. And you take a breath out, they do some degree of internal rotation. Another quality that we need to know is a reciprocal tension membrane. Our RTMs function to keep a balanced state of tension between all of the areas of attachment. This is how we're describing the dura. So that the skull is not, if pressure gets put on the skull in one area, it has to be able to distribute it to another area. And that makes sense to me from just a physiologic point of view. Otherwise, you could not take any of the traumas that your brain is going to receive. And your brain doesn't like trauma, physical or emotional. We can later on tie those ideas together. You have other areas of your body where tension is distributed along membranes to balance tension. You have two other areas where you have something like this. Any thoughts? Nothing.
No.
Nothing going on.
No,
Huh?
I mean, I feel like that's sort of throughout your body in the biotensegrity model.
Yeah, actually for biotensegrity you could say that. So you just killed me on that one.
Sorry.
No, that's all right. That's all right. That's not what I was looking for, but you're correct. Your interosseous membrane here. If I go back to the karate example, going like this and breaking a board, we can go into a much more complicated example. The forces have to come through my wrist here. Your wrist doesn't articulate with radius and ulna. It only articulates with the radius. But your radius doesn't articulate with your humerus, only your ulna does. That force has to be translated through the interosseous membrane, and it depends how you orient your hand. That's why you go like this, the board breaks, and it goes like this. You go like this, and your wrist breaks, and you look like a fool. But usually it's associated with alcohol at a bar. So there's no mysticism in the karate, it's just distribution of forces. You also have one between your tib and fib. Your fibula is not there for weight bearing, it's there for muscle attachment. So we see, I just want you to understand, I'm giving you all this preamble for a reason. I'm not asking you to believe, I'm just showing you different pieces of evidence why I think this works. You're not going to convert one patient, except your loony patients that are suffering from TMM. Then it doesn't matter. TMM, it's too much money. People that have too much money, it doesn't matter. I don't worry about converting people. I worry about treating their condition. And if that makes a difference, they don't care what I did, why it worked. If what I did didn't work in a couple treatments, it doesn't matter what I say to them. I want you to come and keep getting treatment. They're not coming. So the belief or the proof, it's for you. It's not for the patients. Sutherland Fulcrum, we call it that, named after Dr. Sutherland. It's that shifting point about where we believe the middle of that tension is. And I would theorize that it's in the straight sinus. Nobody's ever proved this. I would compare it to, a teeter-totter. This is a fulcrum, okay, a balance point. This is how we do a seesaw. Here's a picture of me and Paul on a seesaw. Okay, is there a way that I can sit on the seesaw and Paul can sit on the seesaw and to have balance? There is. We just have to shift that fulcrum. So this is what, in cranial theory, or if you took some other course, they talk about the Sutherland Fulcrum and the idea of a shifting balance, that there's some shifting balance point within the skull as the skull is deforming. Is that going to be a rationale for your treatment or change your treatment? Not at all. I want you to have everything that I have from primary sources. I want you to know what the Cranial Academy people talk about. I want you to know what the Upledger people will talk about. I want you to know what Dr. Fulford talked about. I want you to know as much information as to why we should do this. All right, let's look at our actual motion, what we're calling flexion. What we're calling flexion is, we're saying that during the flexion phase, and again, if this had, I hope you're paying attention to this, Harry. You've already solved that cube. You'd be really good at this. That cube, me, I would have done it like 5 seconds, out the window. I just do not have the patience for it. But he's the master. So what we're saying is during the flexion phase is that something, whether it's a biodynamic model, a cranial model, a biodynamic model is coming in the next slide. Something is causing this to shift, okay? And it's a slight coming together from anterior to posterior. That slight coming together anterior-posterior is allowing this to get a little wider, okay, along the width. That's what we're calling the flexion phase. The biodynamic model says that that's happening because of an electrical stimulus or a genetic stimulus. This is around 15 days in utero. In 15 days in utero, you had the primitive streak come up. And if you probably had in biology somewhere where you did the primitive streak in an egg. Did you ever do something like that? Nothing. After like 72 hours, an egg gets this little streak primitive streak comes up. Before that, you were just a blob. Okay, you were a blob. You had no up, no down, no front, no back, no left, no right. At the moment you have this primitive streak, you now have what we know will be the top, we know what will be the bottom. Soon after that, when the cells start to migrate, you have a left and right. This is what the biodynamic model says. The biodynamic model says that flexion was that electrical impulse that started that primitive streak. That's a very short snapshot of what that theory means. That what we're feeling, this cranial rhythm, is an energetic thing. It's not a physical thing. I think all of these things are happening. Absolutely, there's a physical opening between the sutures, and it's movable. Lastly, just some miscellaneous slides. This is what a venous sinus is. Venous sinus is wherever this door comes together. It is not a vein. It's not something that is contractile in the way that a vein is contractile. It doesn't have valves. Your veins have valves. Why do your veins have valves, by the way? To what?
The little lymph flow.
Veins have valves, lymphs have valves because it's a low pressure system to stop backflow. It's kind of cool. I mean, we were taught to try and think about how the body works. Actually, I know this is just, we're talking about cranial, but osteopathy, where I come from, is based on, doctors still want people to study the anatomy and physiology and create whatever techniques they wanted to get whatever results you needed. It didn't have a conflict with self-invention, as long as it was based in anatomy and physiology. And what has come afterwards in osteopathy is do as I say, or you're a bad person. Okay? So if we look at how the body really works, it's pretty amazing. And that does guide. It guides what we do, in a way. So venous sinuses are just venous spaces where blood collects. Here's a side view. This is that area that's called straight sinus. This picture sort of makes it look like there is a structure inside that webbing. It isn't. It's just a web that comes together and creates that space so blood collects in these sinuses. Okay. I don't know if we really need a break. I'll just go on to the next thing. You know how this got this way? What is this? You know what this is? There's a name for these. I forget them. It's somewhere from the Indian culture, one of the Indian cultures, Mayans or Aztecs or something. This skull was made this way. This person would have been a priest or something like that. They would have determined in the culture, and they made this head grow this way. They would have taken this child and bound the head to a board. I have other photos for another lecture that you can. This one you can't see the suture lines too well, but this will all be occiput here, and this will be all parietal. If you bind the skull and you restrict it, it will grow. And FLKs don't look quite this dramatic, but some of them, parents will cover it up with hair. Kids will have weird hair.
No, it's fine for
Pardon me?
FLK for people. FLK, we'll go with it.
Yeah, they were paying attention while you weren't.
We're getting you water.
There's a throwback.
Yeah.
I'm in the right town for guilt, right? It's funny, my wife and I throw it back, and I said, I didn't know that, you know, I'll leave it off. My wife has learned the guilt thing, really good to throw it out at me. All right. Any questions so far? That's just all our overview. No?
Bind your head like.
I don't know how they did it,
Yeah.
but they would have bound that head front and back to a board. That's the only way you can explain that growth, and the head would have grown this way. Because it's almost grown a little bit like the name would be oxycephaly, but not quite. Oxycephaly is when you restrict the coronal suture and the sagittal suture. Those kids grow with a cone head. But this is kind of a cone going backwards. So they would have tied this kid's head to a board.
Let me ask you, I don't know if this is coming, but I'm sort of a fascia-y person, and
Me too.
So the difference between, you talk about periosteum on the inside of the skull, and the dura mater, which is the fascia, right? And so
Yeah, it's really an extension of fascia.
right. So what is so the periosteum is like pretty dense fascia, right? Not like the. Do you know like what the fascial make? What is that? What does dura mater look like as far as fibers or orientation?
I can't tell you the difference between that and periosteum.
Yeah.
I can't tell you what that is. There
Similar,
probably
maybe.
is, but I can't. I don't know what it is. But you can separate them. Okay, and the periosteum is not going to be. Well, we can make the argument that it's contiguous everywhere.
Right.
Fascial models are great. Me. Some people that came to osteopathic school, they were chiropractors before. They were PTs or some massage people. I was a karate guy, so I had none of this background. So what we learned in our first semester was some kind of very demure fascial stuff. And that's about how much I got out of it. And I said, I'm never going to do this. And osteopathic school is medical school. So we did this, and nobody cared. If you flunked biochemistry, you were in big doo-doo. Okay? Then second semester, because it's an osteopathic school, you know what we did next? I have to tell you this. We went from, how's that? Oh, I feel the release. Yeah, I feel good. Okay, I got a B. We went from that to cracking necks. So you can imagine how that went. Went home, heard all our friends, heard our family, and said, we're never doing any of this stuff again. Okay? And what I had become, I hate to label myself, but I do mostly cranial, fascial, visceral. And we can make the argument between visceral and fascial being an extension of the same model. Visceral people say, oh, no, this is ours, and fascial people say, oh, this is ours. There's just, it bleeds all over. One bleeds into another, but I don't know I don't know the difference between one another.
But we can assume all the same things. Sensory receptors in there, or?
You have sensory receptors in your dura, and I don't want to tell you things that I don't know that I'm just humming around, okay? But, so I don't know if you have sensory receptors in your periosteum, don't know. He knows, but he's not telling.
I mean, in most periosteum you do, I assume you would have a difference.
What I know is your body has sensory perception that we know, or we try and find out. John made a big deal about wanting me to understand that there's a sensory fiber in the dura. I don't know what it does, but he believed it was getting feedback to the CSF flowing, because that's his model. What I do know is I've treated a lot of people that have been amputees for a variety of reasons. Some war-related, and some diabetes-related. And it's very common to feel pain in the limb that's no longer there. Okay, and not everybody's crazy. I don't want to rule out crazy. Crazy, we could. I know crazy really well. I do crazy. Okay, but phantom pain is not something that's a rare occurrence. And I've dealt with a lot of motility issues on uterine dysmotility issues on women that don't have a uterus. Okay, now this we're never going to prove in the the osteopathic acceptable scientific world, but the patterns for pain or patterns for neurosensitivity might not be something we can dissect out and cut out of a cadaver. Maybe it's energetic. Kirlian photography will show that there's still a broken pattern of something there. So it all starts to go into something that the answer is, I don't know. But palpably, you can make changes. You can try to make changes. Any other questions? I'm 6'1", hazel eyes, I like long walks at the beach. I was on the road. Just kidding. It's an internet world. It's an internet world. All right. Why is that not doing? Here we go.
Does anybody need a break right now?
Okay, I want to get on the table soon, so let me just do a little bit more talking, and then we're going to do right now diaphragms, which we could do in a fascial course, we can do it in a cranial course, and we're going to do it in a cranial course. So. Well, this was a little movie with the cars going. I don't know why it's not going, but I call diaphragms crossroads. I call them a crossroad. For me, a diaphragm physically, I'm going to call it an area where you have transverse fascia within the body. Diaphragms are they're important in fascial technique, they're important in cranial technique, they're important in visceral technique. If we're talking about ligamentous articular strain and Roland Becker's work, they have all these people have their view on it. For me, diaphragms are areas where just physically, someone who steps on the brakes and didn't hit the door over here, but they had left shoulder pain, if it's a physical vector, it had to cross somewhere from right to left, front to back, along some fascial plane, the same as the karate example that I gave you. And fascia describes that for me. Fascia, these crossroads separate different areas of different function, different pressure. Abdominal and pelvic diaphragms, we can relate treating diaphragms to all of these systems very directly, okay, because of these different pressures. Doing something for your abdominal diaphragm, your pelvic diaphragm, can absolutely change your respiration. If we change your respiration, get you to breathe a little better, same as you will get, same benefits you'll get from yoga, Tai Chi, and other types of breathing exercises. This is not just a mysterious thing for me to say. We will increase your oxygenation a little bit. We will increase your cardiac output. Absolutely will increase your stroke volume. Your cardiac output, which is how many liters your heart pumps in a minute, that's a calculation. It's how many beats times how much went out in a stroke. The stroke volume of your ventricle. What goes out in your stroke is a calculation by what went in. What went in is a calculation by about 30% from your atria squeezing it in, and about 70% falling in from the IVC, from negative intrathoracic pressure. So if you actually take deeper breath or you breathe a little better, it will increase your cardiac output and certainly your lymphatic drainage. Your abdominal diaphragm is your 24/7 lymphatic pump. Aside from your muscles squeezing and causing things to move, it is your breathing. We can relate it also less directly, but to digestion, reproduction, and axial skeleton. This is what I think of when diaphragms are working smoothly or they're not very restricted. Everything's orderly. When it's not, it's this. This could be India. This is Cairo. This is probably, I know a lot of places, a lot of you have been in the world. And you know, you're this guy here, you're like, I'm never going to get there. That's when they're not working well. Diaphragms. We're going to consider the occipital, we're going to consider this tent to be a diaphragm. And we're going to say, well, that's not transverse. No, it's not. Okay, this doesn't all fit into neat little categories. We're going to call this, cranial people, myofascial people, we'll call this area of the occiput, releasing the occiput, a diaphragm. Who would you want to treat for this? Many places I go, I get bombarded with questions of what technique do I do for this and what technique do I do for that. And so I have to always include a little bit of that. Just doing a release just for this either occipital bone or this occipital diaphragm, there's a lot of things that may just affect just that area. Remember I said in the beginning we can do treatment for local reasons, regional reasons, or global reasons. A local reason, according to the Cranial Academy and other people, would be to do a release for the occiput because we believe you have something wrong with the vagus nerve or the hypoglossal nerve, so we want to release tension around the brain in that area. That's a very localized reason to do it. A more regional reason is to do it for any head and neck problem. You've tried to do everything else for them, and this nerve supply goes all the way down to the thorax, goes all across the face, just to do it something that's going to help for that whole region. A global reason to do it, which is more appealing to me, is that you find that the head is restricted regardless of what it is that they're complaining about. Or in the case of cranial, you spend 5 minutes and go around the vault. When I learned cranial, we did it, as most do, as just like 45 minutes or some sort of, really long procedure where all our consciousnesses are raised and we all vibrate to a higher level. And then I got to reality, which is I do cranial in 5 minutes. 5 minutes. And what I saw is the results are nearly the same. So I'm going to show you something that's going to take us probably, by the time we're done, it may take you 15 to 20 minutes to be comfortable doing this whole protocol. I want you to understand I do it in about 5. I touch somebody's head in their occiput until I feel it start to change, and I'm done. I move on. That's it. That whole time frame that I was taught is not necessary. I want to tell you, it's not necessary. I'm not invalidating it. If you've learned it before and someone said you need to spend time and you need to do this, I'm not invalidating. I'm just telling you. I spend 20 minutes with a patient, and I've always worked alone my whole life. 20 minutes has been from you coming in, making yourself comfortable taking your shoes off to you leaving, okay? It means you got to collect your shoes, much to my chagrin, probably put them on in front of me instead of out in the waiting room, and the time is running for me. And it hasn't affected my results, especially with children, okay? Children you cannot coddle. Adults you can coddle. Adults sit there and watch the clock. Want to make sure they get every ounce of your soul for what they paid for. Okay, babies and children never want to be on the table anyway. So if I get the release and I let go, if you really do believe the body has the ability to heal itself, then it really doesn't need you to be married to it. It just doesn't. In my room, I've always worked out of a treatment room. Even when I had 3 treatment rooms, it was only me, myself. So I had a clock, and a clock. So while I was talking to you, I wasn't looking at you at all. I was looking at the clock behind you because I got somebody else waiting. So this is not time dependent. It is palpation dependent. Especially, I know you guys work a lot faster than I do. If you're acupuncture, they started my acupuncture hold. I want to go through 5 or 6 quick slides, and I want to show you the hold that you're really going to do. I want to show you another hold that you should hear about because you'll hear about it, and I don't want to be the guy who didn't tell you about it. But frontal occipital hold is going to be uncomfortable. You're not going to do it. This is what you're going to do. You're going to grab people this way and try and palpate something. This is from, it's called Atlas of Cranial Manipulation, I think it's called, by Alan Gain. And there's a lot of good pictures in there. I can't draw at all. I can do stick men or whatever. Yeah, I can do that one. I can replicate that one. So some of these pictures I don't agree with here. I was taught very specifically, never put your hands over the temporal bone while you're doing a vault hold. And I was given all these rules, okay? You have to understand, in the osteopathic school, most osteopaths are not going to do manipulation. We only did a little bit of cranial. What I learned was outside of school. The reality is, as long as you know what the anatomy is underneath and what it is you're looking for, you can break all the rules. Put your hands wherever you want, okay? If I'm putting my hands, and we believe this is the event that's happening, okay? This is our event. The base of the sphenoid and the base of the occiput is going to rise up. This should be tilted a little bit this way to match the skull. If this is rising up, and this is a wheel, okay, this model, everyone's model uses this kind of cogwheel, like a Swiss watch. If that's what's happening here, then as this goes up, the backhand must be going down, okay? If this is the greater wing of the sphenoid and this is rotating, here's the greater wing of the sphenoid, it's the dent you have in your skull, then that's what these arrows mean here. During the flexion phase, there should be some sensation going down. During the extension phase, there should be a sensation of coming up, occiput and greater wing of the sphenoid. I think you may just feel like it's a balloon filling up with air and a balloon going down. But hopefully you feel something. This you're not palpating, it's inside the skull. This you can reach, this you can reach. There's another hold that we learned, frontal occipital hold. I want to show it to you, you're probably not going to use it. One, I got big hands. I can hold a basketball with one hand, and it's not comfortable for me. It'll be less comfortable for you, especially if you have someone with a heavy skull on your hand and you're doing front and back like this. I think you'll be uncomfortable. No matter what I can show you, if you're uncomfortable and I tell you to do it, the only thing you're going to feel is your own discomfort. So the first rule is you really need to be comfortable. But the same idea applies if you do this during flexion. Okay, that won't show up. During flexion, this is coming down toward the feet. The occipital squamous is coming down to the feet. Okay, we say that the single bones, so you have one bone. I'm not talking about how the bone developed. Frontal bone developed from 2 ossification centers, but you have one bone. It's going to do, this is flexion, that's extension. The occiput is going to do flexion, extension, flexion, extension. The paired bones are going to do something we call internal and external rotation that I'll explain when we get to it. Our theory is, can you hold this for a second? Just like that. Our theory is we're saying that here's your inion and here's nasion. That from here to here, this is shortening a little bit. And that shortening in that door is allowing this to get slightly wider. It all fits, thank you. It all fits with our mechanical model. We try and keep this model as much as we can. And actually, if we separate all the bones and put them together, you can make this sort of motion happen if we have like 6 hands holding different parts of the skull. Let's do that. Okay, so we're going to start the tables. I'll demonstrate on a table. Harry, you let me know where you can see best. And maybe I'll go in the middle if you can get it. Okay, so this is a vault hold. You'll see a lot of different things in books. And let me try and clarify all this. You need to be comfortable, number one. So if you're sitting here like this trying to do it, this is not going to be comfortable for you. You're putting people on the table, I put my forearms on the table. This way there's no gravity for me. I do a lot of cranial, I do a lot of myofascial, I do a lot of visceral, and I do things that are pushing and pulling, and everything is not pleasant that I do. I do my happy stuff in the beginning, I do all my torture in the middle, and then I do happy at the end. And my goal is I do some hypnotic things that if I have time I'll show you that have nothing to do with osteopathy. My goal at the end of treatment is that's my goal.
One more time. Got it.
Half the adults fall asleep, none of the babies do. They're all screaming, yelling, crying, hysterical. I just do my treatment and get done. So you have to be comfortable, number one, no matter what I show you. My wrists are also not that flexible anymore. So, also the skull is very different than your skull, because you'll look, especially if you look in Gayen's book, he'll show you all these different handholds around here. Okay, really? I'd like you to do that on yourself now. Okay, I'd like to get your fingers and get them around the zygomatic arch. Anybody who does that, I give up the microphone to you, and I will sit in your class and you tell me all about it. Okay, this is not real. When you start putting a bunch of stuff around here, you're what we're calling the greater wing of the sphenoid, which you need to palpate, and the occiput, which you need to palpate. And some of you that might have small hands, if you're working on someone with a big head, you may have to make a choice. You can't get to both of these areas. You'll see me do it with my thumbs. You'll see books doing it this way. I don't care. The goal is I want to feel what happens between sphenoid and occiput. That's your number one goal, to palpate cranial rhythm. In this course, I'm going to teach you how to palpate rhythm, to be prepared for it. If you don't, I'm going to teach you how to release the whole vault. And you can walk out of here feeling no rhythm, start releasing the vault, spend 2 minutes on your patients for the next few weeks, you'll start to feel some rhythm. The moment when you start to feel some rhythm, it will be an improvement in treatment. What will that improvement be? Will it be your patients are going to get cured from cancer? I don't know what it's going to be. But what it will be is you're now going to be seeing them on a deeper level. In order for me to know the messed up dance that your body is doing, I have to be able to match that dance. I have to be able to feel it. Osteopathy or cranial or healing in general, you don't impose healing upon people. Okay, you offer it to people. That's what you do. You give them some candy and you offer it to them. And you offer to care about them and to love them as another human being on the road. And you have to feel that way about, a dirty, greasy, grimy guy, and you have to feel that way about a beauty queen who walks in. And both of those can pull your emotions in different ways. Okay? On the higher part of osteopathy, you need to be clear. And that's difficult, because our lives impinge us all the time. Me, it's the one thing that I've been able to do. I leave my traumas at the door and I put them back on as soon as I walk out. And then I stay up and consternate about it all night and sweat and worry. My mother was very good at giving me those qualities. So I'm an Olympic warrior. But in work, I'm not. Turn it off. Because you want to... Cranial rhythm, forget all this theory. I think there's something their body is doing, right? It's a living human thing. And you're a living human thing. And now we're two things together. It's like you're joining a dance, but one of you has to be clear as far as what's going on. So you have to empty your mind. You can't concentrate it into being. You have to be nothing into being. It's there. So if this is flexion, if I pull this apart, we'll never get back together quickly, I expect, but that won't be my problem. It'll be Paul's problem, so who cares? Okay, so if I pull this guy out here, we're just saying that I'm exaggerating this because you're not going to see this motion, okay, between occiput and cranium. You're not going to see it. You're going to become aware of something. Okay, so your thumbs. I'm going to touch my thumbs. It is easier for me to discriminate what's going on if I have this as one tool than if they're not connected. And it's just a choice. But for me, I think this will be easier for you to connect with them. I forget what the name of that neurologic thing is that you know how to do this, that apparently alcohol has some interference with. But you know where you are in 3D space. So once I do this, I know where my hands are in 3D space together. It's easier for me than doing this. I'm not trying to separate sutures and do all this other pushing and pulling. Just sense. The occipital hold is like this, okay? And you're not going to span all the way across their head. And I think most of you will find this to be immediately uncomfortable from the time they put their head in your hand. When I'm doing this, in my office I have pillows. Pillows makes your whole life easier. You put their head under a pillow, and then all you need to do is form around their head. Okay, so let me have someone lay down, please. Volunteer from the studio audience.
Okay. There we go. To the right.
And glasses off, please. I don't do mantras and things like that. I don't say things to myself. I had one teacher who had like a pocket polarizer, had one here, one here, one here, one here. I don't know if it helped him because he was Darth Vader anyway. So I've met a lot of great people in my life, and I'll just use some names that you know. John Upledger was one of the greatest men I've met. To know him as an individual, and he was very clear. One thing I know about John, forget the courses and what happens when there's 100 people at the pulpit. Things are a little different than one-on-one. And I did a lot of my fellowship with him. He was absolutely clear. Your problem is your problem. My problems are my problem. No mantras, no nothing. He came into the patient, and I'm not becoming you. You're not becoming me. And my experiences on another person, name that you would know, is Baral, and I think Baral is a very good man, but different. Baral is very specific about your energies here and my energies, and I'm not. I think these are all great people that I've met, but Jean-Pierre has a lot of rules in how you're going to do this and come into another person. John has none, and I like that. It's almost it's instantaneous. It's by epiphany. Your problems are your problems, and believe me, you don't need my problems.
Agreed.
Yeah. You don't need my problems.
Right back at you.
Right back at you. I have patients that come into me that are at the end-stage cancer, end of their life, or their children just died in a car accident and horrible things happen. I don't make everything funny, everything a joke. I try and be humorous when I can. Sometimes I can fix your problem, and the thing I can do is maybe make you smile. And that's maybe the best therapeutic thing I'll do for you today. Sometimes the people's problems are too big, and I will do all kinds of crazy things. What I just did with her, I do. I had a guy. I just saw him now. I was in Philly. Him and his wife. Their problems are such a cascade of disaster, and I do it as charity. I do a lot of charity in my life. And he was kind of tuned out one day, and I just put my head right over his head, and I waited till his eyes opened, and I said right into his eyes, I said, 100% of Steve Sant is too much for anyone to take. And he just laughed, and he said, whatever's wrong with you is no little thing. So I am very much interested in her being well. I am not married to the outcome of her getting sick and dying. I pray that she doesn't. I hope that she doesn't. I cannot give her from me to Steve Sant, because Steve Sant, I don't have that many chips, I don't. But if I give her my attention, I believe in others in my profession, that if you are a conduit, whether you believe it's, again, whatever your religious faith is or no religious faith, whether you believe it's energy, none of that matters to me what your interpretation is. But for this to work in the clearest, most purest way, I have to be empty. And from a point of being empty, she will show me what's going on with her. She'll tell me one thing, and that's a lie. It's not an intentional lie, People will tell you, my back hurts, my neck hurts, this happened to me, here's what the other doctors think. Another friend of mine, this guy I trained who's an orthopedist out in Missouri, he gave me the exact numbers on this thing. You know, you take your complicated case to a doctor and you show it to the next doctor to get your next opinion. What do you think that doctor is mostly trying to do? To prove the other doctor's right or wrong? They're mostly trying to prove them right. They're mostly trying, if it's just human nature. If Paul sends somebody to me and says, Steve, I think blah, 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 and I know Paul, I don't instantly think that Paul's wrong. I think maybe Paul's got good insight. And it's just human nature. I'm not saying that the people, doctors, are evil or fallible. We're just human nature. I go, well, I like Paul. And if somebody who I don't like sends me, I might think, well, maybe he's really wrong. But there's a big impetus to go through a big pile of a complicated case and say, well, yeah, those tests say this. Yeah. And for me, this is really personal. I still like it. I still like what I do 20 years later. I still entertain myself. The multiple streams of personalities that you're now being exposed to, I'm really entertaining for myself and for apparently some people, not others. At the end of the day, if I'm charging her a lot of money and I don't fix her, she's not coming back. I'm not that funny. I'm funny, but I ain't that funny. And you never know when something magical will happen on the table. And the magic will happen from doing a basic vault release really well. And you know how you're going to do that? You're going to have to merge with her. You're going to have to become empathetic with her. You're going to have to know how she feels. But you're going to have to not feel sorry for her. That's hard with some babies that are really sick, maybe. Or some people. It's hard with family. Family's hard because you can't turn them off, much as you might like to. This is really personal. People let you into their lives. I'm still entertained with it. I really am. You know, I'm grateful to be here with you all, but this is the real me. I don't have that much of a facade, actually. 2 drinks and it's all gone, by the way. All gone. 3 drinks, I'm getting arrested probably. But if she lets me in, I do love her. I'm not in love with her, but you have to love her as one human being, as from you to her. Things will be different. Great people that I've met. Fulford was at the top of my ladder. The difference was he was clear, crystal clear. You have to realize I may do everything I know how to do and she just may die anyway. She may leave with the same headache that she had. She may leave with her complaints. It doesn't invalidate me as a therapist because I don't fix everybody 100%, 90%, or 80%. And I can't think about that. This is supposed to be about her, right? That's what she asked. That's what she deserves. It's so much more than flexion and extension, which is what I was taught. What I'm going to do when we get on the tables, I'm going to go around, I'm going to help you see how your hands are placed. I am not going to do what was done for me. Put my hands over your hands a lot and say, do you feel that's going into flexion? Because there's an overwhelming lobe in your brain that's going to say, yeah, I feel that. That you do or you don't, or it just becomes gray between you and I. If you don't feel it, it's okay. If you put your hands on people, you will, and suddenly it will feel like it is a live piece of jello moving around. It's not like people their heads started moving more after you got more experience. It's just that you got quieter inside. And for me, I can be perfectly quiet inside and have a dialogue with them. That's another thing. And maybe it's me particular. Sometimes my patients will see me going like this, they think I'm praying or something. No, I just don't feel like talking to them. I close my eyes. That should end the conversation pretty much there. Okay? I just don't feel like it. If not, I'm happy to talk about the weather, talk about baseball. Well, not really, I don't like baseball, but the two things are different skills for me. I don't have to concentrate to feel this. It just is. In every fiber of her body, she's going through what I'm calling a cranial rhythm. And there's other things that are playing here. It's a question of what you want to turn your attention to. I don't ask people ever, does that feel good? Oh, no, I'm not stepping into that one. You're not here to feel good. You're here to get a problem fixed. The only thing I tell people is if I do something that's uncomfortable, you let me know and I'll slow down. I want her to understand that as a therapist, she can put the brakes on me and that I will respect it because I will do things that are uncomfortable to her. Okay, this is the greater wing of her sphenoid. This is her occiput back here. These fingers, according to the way I was taught, shouldn't be on the head at all. I'm supposed to be off the skull and not sensing that. No, I'm going to put my hands here. Why? It's comfortable for me. And Steve Sand's comfort is number 1. Her comfort is number 2. So I'm just laying it there. I'm just not paying attention. You're going to form around her head. You have to become part of her. All right. I don't want to talk it to death, but I think that I think it deserves a little bit of talking. You know, aside from all the techniques, which we're going to do plenty of techniques, I get killed with that constantly. That's more of a third world thing. We need more techniques. Okay, push here, push here. The technique is you, how you touch. You don't do something to her, you do it with her. So I set up verbiage for her to be comfortable. I set up verbiage for her to know that I am not going to steamroller over her. I try and read her as much as I can emotionally when we're getting into a tense area. You're doing this for a physical thing. She says, I have a headache and this brick fell on my head and I need you to treat that. You don't know if that's what the problem is. That might be a story that happened to her. You don't know if that's actually why she came into your office. You have no idea. You have no idea. It's just one human being who came in and it's going to unfold like a flower. And it might be a horrific flower. So I'm going to come into her. And there's all kinds of levels at the moment where I touch her. Small touch. We read it all the time. Tiny. Microscopic. The smallest touch we know. Okay, so what I want you to do is, you're going to be comfortable on the table because you're going to stay here on the table, and I want everyone else to come up and we're going to do a vault hold. You can use your index fingers, you can use you'll see me doing my thumbs, and you need to be on the occiput. And you're going to relax and see if you can become aware of something that is changing, whether you feel like the skull is blowing up and down, or whether you feel this motion. It doesn't matter to me. I want you to feel some slow change that takes 3 to 5 seconds one way and 3 to 5 seconds another way. If you don't feel that change, I would like to go out in the hallway and castigate yourself for a while, punish yourself. Try and see where you went wrong in life, call your mother and your father and see what they're responsible for, then come back in the room and join us. And then I'm going to rotate you very quickly. I'm not going to let you get too lost in the moment. I'm going to give you a couple of minutes and then I'm going to move on. And I'm going to move you on to another body, okay? It's really hard to stay focused on this situation because life impinges on us. It does. But me, this is like, you know, when there's a car accident, there's reasons why all of traffic slows down. And you're like, why does everybody have to stop to see the head rolling down the street? Well, this is the head rolling down